Rafa Medina.
Hi, everyone. Hope everyone is having a good weekend. So I'm going to start with the case that we had on Monday. This was subspecial oncology subspecialty VMR with Dr. Sam, Dr. Mira. So this was a 7 to 7-year-old male that presented with progressive back pain, not improved by rest or exercise, and he was found to have numbness, tingling on the fixed exam, as well as an enlarged prostate. Labs revealed elevated PSA, and this patient was found to have a 4.4 centimeters renal cell carcinoma. So the first teaching point here is whenever we see back pain, we should think about the red flags. This patient had several red flags, right? So the progressive nature of the back pain, because you actually expect the back pain to be improved less than a month when it's a benign cause. It was not improved by rest or activity, so you could rule out mechanical causes, for example. And there were numbness and tingling, so it means that the patient had neurological deficits as well. So, and besides the red flags of the back pain, one teaching point that Dr. Sam and Mira taught us is that the spine is actually a very common site of metastasis. And the primary cancers that you have to think about, it's the prostate, the lungs, the colon, and the breast. Anything else to add, Robbie?
Oh, can you just say that list one more time? A little slower.
Okay, so it's the prostate, the lung, the colon, and the breast.
Beautiful. Perfect. No, that's superb. Nothing to add.
Okay, so the second teaching point, I think it was very interesting. I was talking with Marilyn about that, how subspecialty VMR is so special because, not because I'm the organizer, but because the specialists can give their input, their valuable input. So on the case itself, the final diagnosis was actually renal cell carcinoma leading to metastasis to the bones, but Sam and Miro actually argued against it based on several factors, including epidemiology, because prostate cancer is much more common than renal cell carcinoma, and it leads to metastasis of the bones. It's not because renal cell carcinoma can't metastasize to the bone, but the rate of metastasis is actually proportional to the size of the primary tumor size. So renal cell carcinoma 4.5 centimeters is actually small for renal cell carcinoma. It's actually early stage renal cell carcinoma. It would be highly unusual for a 4.4 centimeters renal cell carcinoma to be metastasized into the spine. So actually, a size of bigger, uh, um, and higher than that, you have to think about metastasis from renal cell carcinoma. Anything else, Ravi?
No, I think it's a great example of how when you have multiple lesions in multiple different places, biopsying only one of them can be tricky because if you biopsied this renal mass, you'd see a renal cell carcinoma, and then you'd make the assumption that the renal cell is going everywhere. But that's a faulty assumption. And that hammers home the point as to why our goal is to biopsy the metastatic site. So if you have multiple lesions and you think the renal is primary, you should try to biopsy the metastatic site because it proves that the site of metastasis is what you were thinking, and it immediately stages the disease. So in a patient who has a pancreatic mass and several lesions elsewhere, you'll see us trying to prioritize the lesions elsewhere. Because if we find pancreatic cancer there, we can immediately make the diagnosis of metastatic pancreatic cancer. But if you biopsy the pancreatic cancer alone, you are still not 100% sure that everything else isn't something either infectious or another tumor. So always try to biopsy the metastatic site when you can. This case was a great example of that.
Oh, but in this case, this patient actually denied care. So he went into palliative care. So they didn't go to the bone biopsy. And Mira actually taught us that a bone biopsy is very hard to get. I think because the bone is very thick, so it's hard to get a good sample. So in the end, this case was that Mira and Sen argued that this actually was a prostate cancer metastasis with incidental renal cell carcinoma.
Absolutely amazing case. So much learning there. And I think goes to show you that you really need an oncologist expertise to plug in all the numbers. And yeah, you're right. There are many sites that have a much lower yield of biopsy than you'd expect. And the two most common ones are bone, because it's just full of hard material, and two, the inguinal lymph nodes. It's very, very common to have inguinal lymph nodes as a site of metastatic disease, but the yield of inguinal lymph nodes is usually very, very low because they tend to be reactive to something else going on. So yeah, you have to know many things about how to biopsy something. And there are many, many different principles. And I think Rafa taught us two. One, biopsy the metastatic site. And two, there are some sites with very low a biopsy yield. Bone and lymph node and inguinal lymph nodes are two big examples of that. I had the distinct pleasure of telling you about Tuesday's case, which was a masterclass of POCUS. I am no expert in the domain, and so will naturally shy away from it because the case itself was just unbelievable. Ravi presented a case of shortness of breath that dropped us in a very unusual space. It dropped us in a space of bilateral lymphadenopathy in the chest and bilateral pleural effusions. And whenever you see lymphadenopathy, you're always worried, oh my gosh, this must be inflammatory in some nature. It's lymph nodes. They're big and irritated. But then they biopsied, they did a thoracentesis and saw that it was a transudate. You're like, wait, what? There's a transudative, meaning non-inflammatory pleural process, but yet there's lymphadenopathy in the chest. And the most common cause of bilateral transitive effusions is heart failure. So they put a probe on the heart and they saw a cardiac mass. In fact, not just a cardiac mass, a left atrial mass, which takes us into the world of cardiac masses. And that is a world that you have to approach with tremendous humility because you don't really know that mass is a cancer. It is a code word for cancer, but it could be a large blob of pus, like endocarditis, and it could be a large blob of thrombus or clot, which happens in the left atrium too. But here, the location, it being attached to the intraatrial septum, was actually characteristic of the end diagnosis. But you have to do some thinking before you go mass equals tumor. In general, metastatic disease to the heart is way more common than primary cardiac disease. The heart literally filters all hematogenous spread. So it's not hard once you make that inference of all the cancers have to spread through the heart at some point, and some of them get stuck. The biggest clue that this wasn't metastatic is it's on the left side. Most metastatic disease to the heart gets stuck on the right side, in the venous drainage. Still, though, left-sided disease is still more metastatic more than primary, but the rate of metastatic plummets, and they become pretty close. In this patient, though, characteristic imaging findings of a myxoma, an atrial myxoma, which is the most common primary cardiac tumor, and is in the vast majority of patients is idiopathic but age-related, usually in middle-aged patients. And so the question is, why would somebody with a myxoma develop bilateral transudative effusions and lymphadenopathy? And whenever you hear cancer and stuff distant, you have to step back and say, wait, does this person have metastatic myxoma? Which are words you'll never utter because these tumors don't have metastatic potential. So in this case, what's the likely hypothesis is that he has the plop phenomena, the atrial plop, where the tumor plops into the mitral valve, causing transient mitral stenosis-like disease. Before I wrap this up for you, bilateral mediastinal lymphadenopathy plus bilateral effusions is usually inflammation. The wrench in this, here it was transudate, which took us to the heart where we found a mass. Mass could be tumor, but could also be clot or pus. Here, the characteristic location favored a tumor. And so we were left with, how can a tumor do this? And hypothesize that it causes mitral stenosis-like physiology. What about the lymphadenopathy? I'll leave that to you to do on your own time. Why does this patient have who has mitral stenosis-like physiology? Why do they have hilar lymphadenopathy? And a quick Google search about mitral stenosis and hilar lymphadenopathy may get you the answer. And I'll leave that to your excitement. Any questions from the crowd? Minus the one that I told you can't ask. Cool. All right, Mukund, Wednesday.
Sure. So Wednesday was a really great spontaneous case in one of my favorite disciplines of medicine, which happens to be kidney disease. This was a 35-year-old man with creatinine of 2.5. and a 1 week history of foamy urine and fatigue, which already gives you quite a few signs about where we might be going with this case. But I'll go through some of the pathophys. We can think about kidney disease as being either pre-renal due to hypovolemia or renal artery stenosis, intrarenal due to tubular or glomerular disease, or post-renal due to obstruction of some sort, usually BPH or a stone or something else. Pre and post-renal, we learned, are by far the most common causes of AKI. And so these should be considered first as part of just the base rate calculation. But we discovered when we did some labs on this person that he had a nephrotic range proteinuria. And so we were led down the less likely of those three pathways, intrarenal disease. And within this category, we've got kind of the two big buckets. We've got nephrotic syndrome, which I'll tell you a little bit about. That is significant loss of protein in the urine. That's defined as 3.5 grams of protein per day or more lost in the urine, and this person was losing 4. And all of the symptoms that result from that protein loss, including hypoalbuminemia, so you're losing albumin, edema, because all that protein loss is reducing the oncotic pressure, and that leads to fluid extravasation from the vessels. Hyperlipidemia, which we think is kind of a compensatory mechanism for that loss in oncotic pressure, but is, again, not a fully understood process. Recurrent infections due to loss of immunoglobulins, and clotting type features due to loss of antithrombin 3 in the urine. So this whole picture comprises the nephrotic syndrome, and there are a whole bunch of different diseases within that syndrome that we'll recap very briefly. But you've got your other bucket. You've got nephrotic syndrome defined by proteinuria, and you've got your nephritic syndrome, which is defined by inflammation. So the inflammatory compromise of your capillary endothelium is going to lead to hematuria, and comparatively less, so less than 3.5 grams a day of proteinuria. Of note, hypertension is also much more common in nephritic than nephrotic disease, although in this patient who presented with hypertension already, that was a bit of a complicating factor. Proteinuria, like I'd mentioned, was the center of gravity for this case, and we did discover in the end that this person had secondary focal segmental glomerulosclerosis, or FSGS. So I'll go down this pathway just very briefly and tell you that FSGS is a family of diseases that's characterized by kind of the same pattern on light microscopy. So think focal, meaning some but not all glomeruli are affected. Segmental, meaning part of the glomerulus, but not the whole thing is affected, and sclerosis, FSGS. Primary FSGS is idiopathic and is the most common presentation of the disease. But this person, we thought, had secondary FSGS. And this is really fascinating because primary and secondary FSGS actually present in really different ways, with primary FSGS having kind of a rapid development of symptoms, the proteinuria, the edema, all of the things that you'd expect from a nephrotic syndrome. And secondary FSGS, which is caused by things like obesity, sickle cell disease, or toxins, have a much more kind of indolent presentation. The symptoms evolve more slowly. The kidney failure is progressive. In many cases, the proteinuria may be subnephrotic, although in this case, it wasn't. And of note, which I found super interesting, there's often no hypoalbuminemia or edema. And both of these things were true in this patient. That was a complicating factor during the case discussion, but we discovered in the end that this person's presentation really does match that of secondary FSGS. So to give a quick recap, pre, intra, and post-renal diseases, of which, in this case, we followed the intrarenal bucket, thanks to the presence of proteinuria. Nephrotic versus nephritic syndrome, with nephrotic characterized by loss of protein, and nephritic characterized by inflammation of the glomerulus. And the ultimate diagnosis was FSGS. So the question I have for you after all of this is actually not related to nephrotic syndrome at all. It's related to nephritic syndrome. This has been a point of repeated confusion for me in my education and my research. I would love to hear your clarifications and explanations for DPGN, diffuse proliferative glomerulonephritis, RPGN, or rapidly progressive, and MPGN, membranoproliferative, where I feel like there's some overlap between these buckets, but they also are distinct categories. I'd love to get some clarification on these three.
Oh, this is the easiest question I've ever been asked. I have absolutely no idea. Zero, none, utterly clueless. So unfortunately, I can't help you with your dilemma, but the fact that you have that as your dilemma is a testament to how much knowledge you have and how curious you are. I think these histopathological terms confuse me as well, and I haven't taken the time to try to clarify them in my mind. Yeah, so unfortunately, I can't help you with that, but I absolutely love the recap and the journey that you took us on it. I had no idea that secondary FSGS is such a subtle form of nephrotic syndrome, subacute, no albumin, no edema. And you can easily see how, if you don't get the key test, which is the urine protein to creatinine ratio, you might easily miss that. Because I think it's not uncommon that people are like, oh, there's AKI, but there's no hypoalbuminemia, so this can't be nephrotic syndrome. And I think that knowing exceptions to that, or knowing that they exist, is really, really helpful. So thank you. That was awesome. Alrighty, on to Thursday. Ariel, take us away.
Thursday's case is one of my favorite presentations, which is altered mental status. To briefly recap, it's an older gentleman who was fully functional 10 days prior to the presentation, but then presented with profound confusion, mobility difficulty, speech dysfunction, and urinary incontinence. The workup physical examination revealed an elevated heart rate, elevated BP, and just profoundly confused, decreased muscle strength. But then we did the workup, the CBC, chemistry, EEG, PET CT, MRI, all normal. Everything was normal. We briefly detoured into how the bladder can, cause altered mental status, and the bladder was normal too. And the diagnosis was revealed via lumbar puncture, and the gentleman had HSV1 encephalopathy. So my first teaching point is, when we talk about altered mental status, we all know the missed mnemonic, but that includes both the intrinsic and the extrinsic causes of altered mental status. And it's important to have a flavor of whether this is inside the brain or outside of the brain. The extrinsic ones are more commonly found clinically, but intrinsic causes can be more deadly. And if we were to have a mnemonic for not mnemonic, but like a schema for intrinsic altered mental status, we think about the brain parenchyma, vessels, ventricle, and meninges. So I like that teaching point. And my second teaching point is more of a question, which is, one, is it indicated to do a lumbar puncture? Like for our patient, he doesn't have much inflammatory signs going on, and everything else was normal. And it's less of an issue in my field, where patients need full anesthesia for MRI and full anesthesia for a lumbar puncture. So when we do MRI or CT, and we usually just do a lumbar puncture right away, because we don't want to put them under for twice, unless we have signs of elevated intracranial pressure. But in human patients, when do you decide you want to jab a needle into the spine?
Ariel, that's such a great recap, and an emphasis on, I think, the most important thing, which is what are the intrinsic causes and how do you come to them? And I think your second teaching point is a very powerful one. That is a conversation we should have, and I don't think we ever had it on CP Solvers, because we usually were so focused on just getting the information. So what would even prompt you to do that? And I think we can start off by saying, well, when is an LP going to unlock a case? And it does so in two situations. The first is the disease that you're looking for is in the meningeal space. So you see bacterial meningitis, or you see carcinomatosis meningitis. You see that the stuff is there. In those instances, the LP returns diagnostic yield. But just like the lungs and the pleura, sometimes if you do a pleura thoracentesis, it will tell you that there's nothing wrong with the pleura itself, but there's a disease elsewhere. So the best example is the case on Tuesday. You had so much fluid in your pleura space. You do a thoracentesis, but it tells you, oh, the problem's actually in the heart. And so the question is, when does an LP tell you that there's a disease close by, a disease in the brain? And so there are many instances where a brain disease leaves its clue in the lumbar fluid, no different than when a heart disease leaves its clue in the pleural fluid. So what two instances does an LP return diagnostic yield? It's when the disease is in the lumbar, in the meninges, or that the disease actually lives in the brain but has communicated in some mild degree with the CSF. And HSV encephalitis is a great example. When we say encephalitis, we're saying that the disease is in the brain, but there's a leak over of the inflammation into the lumbar spine. So the answer to your question, it is basically the folks taking care of patients who are thinking about LPs are primarily worried about a brain problem or a primary meningeal problem. Now, it is a whole other conversation to figure out, well, when should you be worried about those things in the first place? And that's basically what we talked about with like accumulating the clues for a parenchymal, vessel, meningeal, or ventricular issue. Like there's a lot of things that go into that. But here's the really, really important point. You shouldn't do a lumbar puncture when you are very confident that you're dealing with one of these two things, a spillover brain issue or a primary meningeal issue. Because the diseases that you are considering are so morbid, your threshold to look for them should be very low. So ideally, you would perform many negative lumbar punctures to capture the diseases that you're looking for. Many. Now, why does that not happen? It doesn't happen because it's actually a little bit hard to do lumbar punctures in older adults who have arthritis of the spine. And it is also in humans, like it is in animals, procedurally complicated. It takes time. Patients are on anticoagulants, so that makes it harder. But medically speaking, you're looking for a primary meningeal disease or you're looking for a brain disease that spills over into the meninges. When should you get this test? When you're thinking of those two things. When should you think about them? A whole other conversation. But biggest caveat, you should have the smallest hunch that they exist, and that should prompt you to do a lumbar puncture because you want to get, based on your own judgment, you want to get 8 lumbar punctures with no answer to get 2 that with an answer. So you have to be very, very sensitive in doing this test. Yeah. So what's concrete? What diseases cause a positive LP? Brain meninges. What's abstract? What level of suspicion you have of those things that will prompt you to do that test? Does that answer your question?
Yes, it does. Thank you.
Awesome. Well, thank you for that recap. And yes, I was fired on Thursday and I'm making my return here on Saturday, but aided by Madalena, who will recap Friday's cases.
Can I actually ask a follow-up question to
Yeah,
Thursdays before Fridays?
Yeah.
I know this has come up on some of the maybe CP solvers podcasts, but I wanted to hear your thoughts on how you think about CT scans before LPs.
Yes, 100%. A controversial topic because the criteria to do them before was very long. And based on a study out of Sweden is very, very narrow now. So many patients don't need it that do need it. The details I'll leave for you to look up, but the principles I can share. And the principles are the theoretical concern that if you remove fluid from the bottom, that the brain will drop. When does that happen? When there's high pressure in the brain. So when the brain is already being pushed down and you suck fluid out of the patient, the brain will herniate. What are the instances when you're worried about intracranial hypertension? That's the criteria. But the real pathophysiologic concern is if there's pressure on the brain and you suck fluid out of the back, you'll cause herniation. So then it's a judgment call about when are you worried about it, an elevated intracranial pressure. And the criteria for that used to be very sensitive. Like even if there's maybe one microscopic clue that the patient has elevated intracranial pressure, get a CT before an LP. But more and more so, we're realizing that that's actually way too strict because it delays the LPs for many people. So now we have much more specific criteria for intracranial hypertension. Before they were very sensitive. Cool.
Got it. Okay. That was super helpful.
Yeah, you got it.
All right, I guess I'll jump into Friday. So yeah, I had the privilege of getting to summarize Friday's VMR where Travis, Zach showcased the CPC universe, which is an incredible tool to help select and filter any JM clinical cases by symptom, final diagnosis, so that you can find cases relevant to your warnings. It was really cool. In the VMR, we discussed 2 NEJM cases of rapid fire. So I'm going to give a brief summary of each case and then share a warning point from each case. So for the first case, so this was a 59-year-old man from the Caribbean with a past medical history of strongyloides infection and a presumptive diagnosis of seronegative celiac disease, who presented with recurrent acute abdominal pain and weight loss that was CT negative, but endoscopy positive, meaning that there was villus blunting in the duodenum. The patient had represented with fever, a rash, and a repeat biopsy showing a bowel that was overrun with strongyloides, ultimately making the final diagnosis of hyperinfection syndrome of strongyloides due to an immunodeficiency from each HTLV1 co-infection, making that geography we heard about in social history really important. For this case, the filter that Robbie used to approach the analysis was the negative CT scan. So I'm going to summarize a very simplified approach to CT negative abdominal pain as the first warning point. So the causes of CT negative abdominal pain can fall into, is this a luminal issue like inflammatory bowel disease? Is this a vascular issue like mesenteric vasculitis? Is this an endocrine issue like adrenal insufficiency? Or is this a neurologic cause like lead toxicity or acute intermittent porphyria? So again, it's luminal, vascular, endocrine, neurologic. In this case, we prioritized the luminal category because there was a sign from the endoscopy of luminal findings. And just to kind of hear from the group, I wanted to see if the group could tell me, another example of an endocrine cause of CT negative abdominal pain. We already listed adrenal insufficiency, and does anyone have thoughts on what are other causes of endocrine related CT negative abdominal pain? So yeah, we already heard ones. DKA is a perfect example, yeah. So DKA is a big one. Speaking of hypothyroidism and constipation, so uremia and like hypercalcemia are also great causes. All right, perfect. So now I'm gonna jump into case 2 and give a short summary and then another warning point from that one. So case 2, this was an 80-year-old man from Southeast Asia who presented with a several-year history of intermittent abdominal pain and weight loss, who was found to have FDG uptake in several lung nodules and in the ileocecal region, was also found to have a positive PPD tuberculosis test to 8 millimeters, and actually also a positive interferon gamma release assay, and an ileocecal mass with a biopsy showing fibrinopurulent exudate and non-necrotizing granulomas, ultimately with a final diagnosis of intestinal tuberculosis. So the warning point from this case I wanted to highlight was, how should we approach the differential diagnosis of a chronic ileocecal mass? And when I went to, make this teaching point, I started thinking about, well, so what is so unique about the ileocecal region? So I also wanted to open that up to the group, and can anyone think about what's so unique about the ileocecal region that could kind of inform the differential diagnosis? Any thoughts? All right, so I also, didn't quite know, but so luminal narrowing obstructions, yeah. So in the lymphadenopathy, perfect. So the ileocecal area is an area of kind of physiological stasis, so kind of because of the luminal narrowing. And there's also abundant lymphoid tissue there. So really, it's actually the most common area in the GI tract involved by a pathological process. So that's kind of the why for some of the differentials. So really the differential of a chronic ileocecal mass, you should think of cancer, Crohn's disease, and infection. And really the mass should be, you should think of a malignancy until proven otherwise. But if you're in the infectious causes, you can think of some bacterial causes like actinomycosis, fungal like histoplasma and paracoxy, and then mycobacterial like intestinal tuberculosis. And really kind of the base rate, you should be prioritizing intestinal tuberculosis because it's the most common worldwide. So to summarize, because that was a lot of information. So first teaching point, causes of CT negative abdominal pain. Think of luminal causes like IBD, vascular like mesenteric vasculitis, endocrine, DKA, adrenal insufficiency, and neurologic. And then the differential diagnosis of an ileocecal mass includes cancer and its malignancy until proven otherwise, but also consider Crohn's and infection, intestinal TB being the most common worldwide. And the ileocecal region is this special region because there's a lot of lymph tissue and it's a location of stasis. And then the last teaching point is that I wanted to highlight the CPC Universe tool because you can use it to search for cases by final diagnosis or even similar cases. I can even share my screen either right now or after kind of Robbie's question. Why don't I share it right now? I can show you. Oh, I think I need to be made co-host. Oh, let's see. Okay. Can you all see this? Yeah. Okay, so this is, you just type in universeofcpc.com, and here you can search by symptom, you can search by topic, you can search by final diagnosis. So for example, you can just click on here. My Wi-Fi is a little slow. Okay, and so you can select the final diagnosis of interest. So, you can select search strongyloides, for example. And then to make it a mystery, you want to hide the final diagnosis and then search cases. And so here, I think also the size of the dot represents how strongly that, strongyloides was considered in the differential, I believe. And then, if you just click on, I guess this will just show the NEJM cases, and then it'll ultimately link to the NEJM page. So it was just a really cool tool that you should definitely check out, and I'll definitely be using it to search by symptom and things like that. So let me stop sharing my screen. One question, I had a few questions here, but Robbie, the main question I had for you is, you said at the end of yesterday's discussion that strongyloides and tuberculosis were cousins, and so I would love for you to expand on that and talk about what you meant by that. In what way are they similar, and what way are they cousins?
I think that's an unfair statement because anything can be a cousin with TB because it does everything. And so if you do anything, you become a cousin of TB. But I think quite simplistically, if you have a combination of a pulmonary and GI syndrome, there's not many things that do it except TB and strongy. And I think that was not quite the theme that we had yesterday, but that tends to be the theme of strongy hyperinfection, where patients get severe GI manifestations, skin manifestations, and pulmonary manifestations, usually wheezing. And TB is also a lung plus GI. So I think they're cousins in that they cause a very unique combination of things, pulmonary disease and GI issues. And usually it's unusual for somebody to have that combination there are exceptions, of course. You can get metastatic colon cancer to the lungs, but like if you're like, I can't quite figure this disease process out easily and involves the lung and the GI tract, I think TB and migrating parasites, of which strongy is one of the most common, are probably your best bet, and make them by default cousins. But that's totally cheating, because I can tell you that about anything being TB's cousin because it's related to some aspect of the crazy things that TB does. Yeah, really, really great question and a great recap. I think that was so complicated, and I really, really appreciate you doing that. All right, I'll open it up for questions for the audience hanging out here in a second, but wanted to thank everybody watching on YouTube, and hopefully we'll see you around next week.